confident about and what we aren't confident about in the data sets, and to understand the potential benefits and harms, so they can make appropriate value-based decisions. So there are a number of factors that might influence how we make decisions, and these are illustrated in this little circle here. So we've got personal, cultural, social, psychological factors on top of the information. So there's information plus interpretation that guide how patients decide about appropriate therapeutic choices. And so the decision aids are targeted both at the patient population, but also for practitioners to help them help patients along that decision-making journey. So ultimately, there is something that we want to achieve at the end of this. We want to achieve improved decision-making, and this is through a number of mechanisms by providing appropriate information on the choices so that the patients can then go away and make their own decisions. Wrapped up within that, there is also the idea of managing patients' expectations so that they actually fit with what is feasible rather than what they think is imaginable. Two things that a patient decision aid is not. It's not to tell people what the correct choice is, it's to give them the information to let them make the choice, and it's also not there to replace as an alternative to the consultation process. There are a whole bunch of different decision aids that are already out there from different medical specialties, so the fields of infertility, diabetes, heart disease, stroke, and fracture prediction. These all have their own risk calculators or patient decision aids. Our aim with this initiative is to develop the NJR patient decision aid, which is a partnership between patients, statisticians and clinicians. Our aim over the first 3 years of this initiative are to construct these personalised risk algorithms and validate them for use within the UK and outside, and then to link them to a web-based tool. There'll be one in primary care and one in secondary care that the patients and surgeons can then use to make effective decisions together. The data set that we're using this to develop is the NJR resource, which, as you already know, is and remains the largest joint replacement registry in the world, and we have almost 2.3 million records now with outcomes linked data for revision, death and patient-recorded outcome measures in about 65% of patients, and access to other data sets linked through the NHS ID and NHS Digital. So just to go on a little bit about why patient decision aids may be useful for patients in making their choices. This is some data from the NJR from 2012 showing the extreme differences in survival rates between metal or metal prostheses and different other prosthetic types. So the choice of prosthesis has an impact. Age and sex also have an impact. This is hip replacement survivorship data on men and women across different age groups within the NJR data set. And the same, of course, is true in knees. Survivorship varies on fixation type and also on whether you choose a total or a partial knee replacement. These factors all have impact. From the patient's perspective, the question is, which is going to be the best implant for me? How quickly am I going to get better? Will it get rid of all my pain? Will I be able to play the piano afterwards? All of these kind of things people want to know, and as well as how long it will last, so and the complications. So we need to be able to help patients to answer their core questions. So to help us construct the questions and also the appearance of the patient decision aid web-based platform, we have two patient panels. One is Arthritis Care UK patient panel, and the second patient panel is our project-specific study group panel for the patient decision aid. And working in combination with both of these groups, we're evolving the patient decision aid through to its web-based form, which will hopefully be available next year as a beta version. So as part of this feedback we got from patients, how they like data to be presented and how they like questions to be presented. And we had a whole, these are just some examples of the sorts of feedback that we got from the patient groups, and these are being incorporated into the development of the decision aid. So what outputs are we hoping to get from the NJR AR UK patient decision aid? Well, hopefully the patient and the clinician will understand personalised individual risks for the procedure that they're choosing to undergo. We're using flexible models to look at various fixed and modifiable risk factors for both the patient and the surgical choices. And we've got a bunch of different output formats that we're currently trialling. So there are lots of different ways we can present this data. You can present it as smiley faces, or you can present it as color-coded bodies, or you can present it as bar charts, pie charts. But one thing we have found out is that different individuals have different preferences, not only for their choice of prosthesis, but also for how they like information to be presented to them. So as part of the decision aid output, the web-based design will include some preference information on how the patient would like to receive the data, and so it'll be flexible in that regard. And so here's some more examples of modifiable risk factors. How can I change my risk? You can see here with one, this is a BMI example, with one BMI group we have this particular survivorship model, and this is for another. So next I'm going to go on to do a little demonstration of this. So hopefully, James, if we're attached to the internet, I can click on here and take you through a demo of it. This is how it currently looks. It's not the final version, clearly, but I'm just going to need to scroll down for a second. This is how the provisional model will look. So let's say I click on, say I'm a female, for example, then it will ask me how old am I, and if I put in my age and say, for example, I'm 40, this here, on the actual web-based version, you see all of this all on the same page, so there's no scrolling. This is just a function of the fact that I'm showing it on a PC. How tall are you? Well, obviously I'm quite tall, so I'm going to put 1.8 meters here. And how much do you weigh? Well, for example, I'm 1.8, which is quite tall, but I'm also extremely fat. So I'm going to be 130 kilos, and what type of surgery am I considering? I'm considering knee surgery. And next it's going to ask me about my general health. At the moment these are in the ASA grade format, but we will be simplifying this text so it'll be translatable into language that patients can understand. So I'll put myself as ASA 3 there, and then I get a bunch of questions about what sort of thromboprophylaxis I'm looking at, and I'm going to go for low molecular weight heparin, and I'm going to go for TED stockings. And if I just keep scrolling down, what type of procedure? I'm not think. Let's see. I'm going to think about having a total knee replacement. And you know what? I'll tell you what. Should I have a patellofemoral knee replacement? We'll go for that. So I'll choose a pat-fem, and I'm going to just have one done, or I could have them both at the same time, and I'll get a differential risk for that. So I've just scrolled down and submit and find out my risk. So here we go. The drum is rolling. So now it's giving me a summary. It says, you're telling us who you are and what you're thinking of having done. And it is giving, based on 2.3 million NJR records, it's telling you what your revision risk is at 10 years. So you can see with a very overweight, quite tall patient who's quite young, considering a pat-fem replacement, the risk algorithm tells me my failure rate is going to be almost 30% at 10 years for a pat-fem choice. So just to illustrate some contrasts, Will this happen to me? Not necessarily. It's just a risk algorithm. But what can I do to change this score? So here you can see the annualized risk. If I changed my weight down and lost and was now 65 kilograms without undergoing all the malnutrition that's associated with weight loss that may independently affect risk, I can recalculate my risk and see what happens. So you see how BMI affects the risk of failure with a PAC-FEM. So I can further tinker with things. So the current risk at 10 years is 30%. If I was a lot lighter, my revised risk would be 20% at 10 years, which still isn't fantastic. What about if I made a different prosthetic choice? What if I went for a total knee replacement? Then now my 10-year risk is, given that I'm still only 40 years of age, so I'm in a young patient population, you can see that my overall risk goes from almost 30% down to about 11%, 12%. So this is the risk for a 40-year-old patient. So we can see that how, as we modulate different variables, we see the risks change. So this is potentially a very useful a tool for patients to help them make their choices. It may not, of course, actually alter the choices that they make, but at least from a Montgomery perspective, they're fully informed of what the decision-making process is, and then ultimately it's up to them. So the final questions then are, will it improve patient care? Well, at the moment we're 2 years into this 3-year development program. The web-based interface will be available in 2018, later on, when we've finished all of the different risk algorithms that we're working through at the moment. And the next questions are, do patients like it? Will they use it? Do surgeons like it? Will they be likely to use it? And does it change or impact on the decision-making process? And ultimately, will it reduce costs, which is what the healthcare sector is interested in ultimately. So just to summarise then, we, with the NJR AR UK patient decision aid, we're hoping that patients who currently feel lost, confused, unsure about the options that are available with joint replacement surgery, with the appropriate help, support and advice, will make the right decisions, which ultimately will lead to us moving in the direction of greater success rather than failure. This isn't meant to be a GIRF talk, but it is sounding a bit like a GIRF talk. It's all about making the right decisions at the right time to improve longevity of patients' prostheses and reduce the cost to the healthcare system. So thank you very much, everybody, for your listening to this presentation. Happy to take any questions if there are any. Okay, well, I shall hand over now anyway to the next speaker, as my time is up.